Welcome back to my YouTube channel, everyone. You are tuned in to Certified Emergency Tutorials, okay? So this is the second video on sepsis. The first video's overview was we talked about the definition of sepsis, we talked about how to early recognize sepsis, how to prevent sepsis, and how to early treat sepsis, right? So this video will talk more about septic shock. Things did not go our way. This patient is dying. What do we do? Well, don't worry, because hopefully by the end of this video, you know exactly what to do and how to save that life. So before we get started, I want to go ahead and let you guys know I have created a Facebook fan page. Okay, so go ahead and hit the link below. Follow me on my Facebook fan page. Go ahead and hit that like button. If you have trouble finding it, you can just go to your Facebook and search Certified Emergency Tutorials and then like that button. So that Facebook fan page will have updated notes, overviews of what we talked about, things that we might have missed. You can go ahead and comment about it and go ahead and add that. You can also comment what you would like for me to make my next video about, right? But most of all, I think what will help benefit people the most is that I'm going to put the audio version of this on there. So for those who are driving to their next nursing exam, who are trying to cram and want to get that last bit of information in, can listen to this audio version of what we talked about today and hopefully ace that test, okay? So let's get into it. So septic shock. What is septic shock? Septic shock is one of your distributive shocks caused by massive vasodilation. Those endotoxins, histamine, have caused massive vasodilation, which is causing a hypoperfusion of your organs from lack of oxygen to where now your body has to start metabolizing anaerobically, right? So it plays all these different factors on your body, and now your body's creating lactic acid, and now you're going into this metabolic acidosis state and getting very, very sick, okay? So how do we fix this problem? Our goal should be to optimize the oxyhemoglobin, right? Let's get oxygen, perfuse oxygen over to these organs, so now these organs can start metabolizing aerobically, and now you're not secreting this byproduct lactic acid, which can damage so many other organs and suppress cardiovascular, and now your patient can go home to their loved ones and eat that Thanksgiving dinner. Okay, so clinically, what is shock? Shock is you can define shock clinically by saying, hey, you know what? My mean arterial pressure is less than 65 millimeters of mercury, right? Mean arterial pressure meaning the amount of pressure that the cardiovascular places on the arteries to perfuse vital organs. So think about your components of hemodynamics. We have volume, we have contractility, and we have the squeeze. So if we're missing the squeeze, if we're missing the volume, which you can do this in septic shock, your MAP will drop down. So what do we try to do? We try to give volume by giving crystalloids. That doesn't work. We try to fix the squeeze problem by giving vasopressor like norepinephrine or vasopressin. And hopefully that works to maintain perfusion over to these vital organs. Another clinical sign and symptoms of shock is, say, a drop in baseline of your systolic blood pressure. So if I come in 140 and now I have dropped to 92, I'm progressing into shock. Just because I'm not less than 90 or a MAP less than 65 does not mean I'm not in shock yet. You can have a baseline that high, drop down that fast within an hour. You have to be able to realize that and say, hey, you know what? Let's get fluids on board now before it gets too late. Don't stand at the edge of the cliff and tell yourself, just because I have not fallen over that does not mean I'm not dying or dead, right? Take a couple steps back and look at it from a wider angle and be like, you know what? Maybe it's best if I don't stand on the edge of this cliff. Maybe it's best if I stand way back here and prevent myself from falling over. So that's how I kind of have to look at it, Treat it aggressively before it becomes too late, right? So early treatment of compensatory shock is probably the best phase of shock to treat. Okay, so how to calculate a MAP? You take the systolic blood pressure, you add 2 times the diastolic blood pressure and divide that by 3. And hopefully it's above 65. We don't have to bring the doctor and say, hey, can we increase these fluids or can we start vasopressors? Because we've already given 30 cc's per kilo, and you go from there. So what I also like to look at too in the early phases of shock, I look at my signs and symptoms. Am I restless, right? My cerebral perfusion pressure should still be optimal to get glucose and oxygen in my brain, so therefore I'm not altered, but I'm restless, right? It's hard for me to relax in bed, Tachycardia, always the first organ to compensate is going to be your heart, right? To try to feed the vital organs. As I'm trying to speed up my heart rate, so I'm beating at like 120. I'm huffing and puffing. I'm increasing my tidal volume on my rate to try to pick up more, to try to combine more oxygen over to my hemoglobin to feed these vital organs. The one thing we cannot change is our FiO2, right? Atmospheric pressure. We cannot change our FiO2. We can change our rate and our depth, but these patients are not in the hospital from that. They've already tried this. So hopefully they come in, they're set at 89%, you think in your head, let me give this patient some oxygen. Because what he cannot change, he's already sitting there sucking for air. What he cannot change is the FiO2. Put him on a mask or a non-rebreather and give him more FiO2 and then see if those oxygen levels go up. If they are not going up and you hear crackles here, then possibly think about intubating this patient, right? Okay, so clinically, what else do you look for early compensatory shock? You look for oliguria. So now what happens? Baroreceptors start going off, and aldosterone starts absorbing water because your body is trying to maintain hemodynamics. Ross renin system becomes activated, and now Ross activates angiotensin 1 and angiotensin 2. Angiotensin 2 becoming a very potent vasoconstrictor to try to maintain perfusion and hemodynamics to your blood. Remember we talked about that squeeze? You want that squeeze because it adds that systemic vascular resistance in order for your heart to pump against to perfuse those vital organs. Okay, don't wait until you get to uncompensatory progressive shock to recognize this. So because uncompensatory shock consists of what? A weaker myocardium, weaker cardiac output, so now your blood pressure is falling less than 90. Right? Respiratory suppression, so now you're dealing with respiratory acidosis. Hypothermia, so now you're dealing with not only hypotensive and a bradycardic patient, but now a hypothermic patient, right? Don't let yourself go take that route, right? It's really hard to take care of a hypothermic patient, hypotensive patient, metabolic acidotic patient, because now you're thinking in your head, I hope you don't go into hypercoagulability and go into the triad, the hypercoagulable triad of death, they call it, whatever you call it, right? So our goal to treat this type of shock should be to recognize it early, all right? 30 cc's of crystalloids per kilo. We do a passive leg raise, put the patient supine, raise the feet 45 degrees, should help blood increase preload. So preload meaning the amount of blood in the chambers before the heart is able to contract. So now you're filling up the tube by elevating the feet. So there should be a direct correlation behind stroke volume and preload, right? Due to Stirling's law. Direct relationship. So an increase in systolic blood pressure greater than 10% from your previous vital sign should mean your patient has become responsive to fluids, which means your patient can go ahead and get the 30 cc's per kilo. Now if they don't, it's probably more of a cardiogenic issue than anything else, because you can't really fix a damaged heart, by doing the passive leg raise. Okay, so mainstay treatment should be to halt the progression of the endotoxins by giving antibiotics less than 1 hour, or taking them over to surgery if it's something like necrotizing fasciitis and you have all these gas gangrenous bubbles sitting on this patient's leg. Antibiotics are not going to cure that. This is not magic. We can't just do bang, you're clear. Next bang, you're clear. Can't just keep doing that. So the surgery might preserve whatever tissue is left. They might have to amputate the leg or do whatever they have to do, debride it or what. Okay. Then if the person has already got 30 cc's per kilo and the doctor's like, you got a lot of fluids, let's try albumin. You might think that too. Some patients do get albumin, and what that does is it pretty much is a volume expander. So albumins are colloids. Colloids really can't pass by a semipermeable membrane, so they start pulling fluid into the intravascular, and they last a lot longer than crystalloids. So your patient blood pressure, you pretty much are giving yourself enough time to figure out what's going on with this patient, before it becomes too late. So they last a lot longer. So I like them, but some people do not like them, because now if you're dealing with ARDS and you have these interstitial damage, these capillary damage, and the colloids start leaking through the alveolar, and now you're pulling more fluid into the lung space, causing worsening ARDS. So you have to think about it like that too. Okay, so my patient is refractory to all of this. Vasopressors, fix that squeeze. Norepinephrine, right? Epinephrine, vasopressin, vasopressin, or your 3 go-to drugs to fix hemodynamics. Now, if you're maxed out on all these, or look like you're about to max out on all these, you want to think to yourself, what else can we order for this patient? And at this time, a lot of doctors it's controversial whether they'll order hydrocortisone for this patient, but think about what hydrocortisone does. It works on the adrenal glands, the stress hormones, to help secrete glucocorticoids and mineralocorticoids to the cortex and the medulla, right? So your catecholamine, so if a patient is very bradycardic or hypotensive, you want to try to go ahead and secrete that catecholamine epinephrine to kind of help regulate your blood pressure that way, because you could go into total depletion of these catecholamines and secrete none of them at all, which is why we have you on all these vasopressors, right? So glucocorticoids too, and to say something like aldosterone or glucose or cortisol, right? Aldosterone will help your body reabsorb more fluid and salt, therefore giving it more volume to increase your hemodynamics. Now, a lot of doctors are not on the same page. A lot of doctors are like, you know what, there's no evidence saying that it works. You know, that's what we think of when we can't think of anything else. But some doctors will be like, you know what, good idea. Thank you for letting me know, nurse. We're going to go ahead and order some hydrocortisol, 100 milligrams. And we can either give it in a piggyback bag, 200 milligrams a day, or we can just give it twice a day. I've read articles, there's evidence saying that it worked, but then again, I've read some blogs saying that it does not work. So it's really up to the intensivist or the emergency physician at this time. Okay. Other things we want to try to control is the AccuCheck. Like I said, adrenal gland becomes suppressed, cortisol stops working on glycogenesis, blood sugars start to fall. So a main mistake by nurses is not to keep an eye on your blood sugars. Make sure you keep an eye on your blood sugars, because you will tend to drop them if you do not keep an eye on them. Oh, bam. And hydrocortisone will also help secrete more, convert glycogen into glucose, therefore helping your blood sugar. So you can think about it that way. Okay. So other meds they might be on is Lovenox to prevent DVTs, probiotics to prevent C. diff, protonics every morning to prevent stress ulcers and the GI bleeding. When we think about intubating this patient, I know etomidate can cause adrenal suppression. So your blood pressure is down in the 70s. It might not be a good idea to give this person 20 milligrams of etomidate, because it will definitely paralyze your adrenal gland and cause worsening hypotension. So some doctors will use ketamine as a dissociative medication, and sometimes you might not need a paralyzer agent, and then sometimes you might need a paralyzer agent. So if you don't need a paralyzer agent, good for you. When you intubate this patient and put him on the ventilator machine, he is not breathing, you don't have to worry about that positive airway breathing. He's still kind of breathing on his own and helping you try to auto-regulate his metabolic acidosis. Initial vent setting, so say you do an ABG, he comes back 6.9 pH, CO2 of 48, bicarb of 16, PO2 of 68. What are we going to do to this patient? Most likely going to put him in an FiO2 of 100% and start him off to see if we can get his PO2 up. And then what I'd like to use is the winter formula. Right, winter formula, CO2 equals bicarb times 1.5 plus 8 plus or minus 2, I believe. So you take the bicarb, which is 16, times that by 1.8 should be 24, plus 8 will be 32, minus 2 will be 30, and then, or 34. So he should be a CO2 of 30 and 34. Right now he's at 48. So what should we recommend? If he's at a rate of 18 and is paralyzed, is not breathing above the vent, we should probably most likely increase the rate to somewhere around 24, right? Because what compensates for somebody when they're metabolic acidosis? Not the kidneys, it's going to have to be the lungs. You want to blow off that carbonic acid through carbon dioxide. So we increase the rate, help the patient auto-regulate, do an ABG in 1 hour, make sure we don't have to give this patient any bicarb. Normally doctors don't like to give bicarb if pH is below unless it's below 7.1, right? So you want to get it to 7.2, and then you actually give the bodies enough time to go ahead and start, working on the acidosis by itself. Okay, so one more thing I want to hit on is what happens if your patient becomes hypothermic? How do we rewarm these patients? Because hypothermia can lead to ventricular dysrhythmias like VFib, VTAC, especially when you have to put that IG in, for your vasopressors. You nick that atrium, and now you just irritated the heart, and now you just have runs of VTAC or VFib. Especially now if you're also acidotic too and have an increased lactic acid level on top of that, whew, man, those things right there, those three alone will definitely cause your patient to run some ventricular dysrhythmias. Okay, think about how we want to rewarm these patients, right? We want to rewarm them to the core first by using a bear hugger. Don't rewarm the peripherals first, because what happens is all of that vasoconstriction from the drugs and from your body going into shock, that peripheral vasoconstriction is going to cause them to open, right? Because now you're rewarming their body. And what happens is now all that lactic acid starts going back into the heart, and lactic acid suppresses cardiac contractility. Also put your heart at very risk for being unresponsive to defibrillations and shocks and can cause bradycardias. So at this point, you have just killed your patient. So rewarm the cord first at a rate of 0.5 to 2 degrees Celsius per hour, nothing more than that. Or you can cause what they call rewarming shock, right? Think about what happens to the liver. The liver starts metabolizing drugs a lot slower when you're hypothermic, and now you just rewarm the patient. So now your patient is on vasopressors. The blood pressure goes from 120 to 220. I've seen it before, and I was rewarming my patient. I was so happy I got the temperature up so fast, and I definitely put him into rewarming shock. He started having all these runs of VTAC, non-sustained VTAC, but I was like, oh my goodness, what's going on? And it took me a while to figure out after I started researching it more about rewarming that I just caused an overwhelming run of all of this medication back to his heart. So think about how to get these medications when your person's liver is metabolizing slower. Very judiciously, right? You want to give it very judiciously because once you rewarm your patients, then it causes a surge of all these meds having to be metabolized, and then now your body is feeling all that impact and can go into cardiac dysrhythmias that way in shock. Okay, so overview what we talked about is septic shock. I will take out of here early recognition of shock, because since this is the easiest shock to treat, it's easier to catch it early to prevent it from going into uncompensatory shock. Mainstay treatment is to optimize oxyhemoglobin, right? So perfuse those organs. Antibiotics less than 1 hour. Do your passive leg raise, your fluid challenges. Take into consideration if your patient has other comorbidities like CHF, end-stage renal disease, right? Open heart surgery, and they're just recovering from open heart surgery, and they're septic from that. So you don't want to overload your patient and causing this massive ARDS. So we'll talk about ARDS in a couple videos down the road, because that's its own system and there's different treatments for ARDS. My next video will talk about EKG analysis and how to interpret EKGs and how to treat different dysrhythmias. But I really hope this video has helped you guys. Like I said, make sure you subscribe, and I will post this audio over on my Facebook page called Certified Emergency Tutorials. Go ahead and follow me, like the page, and I will see you guys soon.